and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We are recording on February 12th, 2026. On Forefront last month, Director of Brown University's Center for Advancing Health Policy Through Research, Andrew Ryan and colleagues wrote an article titled Value-Based Payment and Managed Care Will Not Solve the Affordability Crisis. Today, to discuss that article, is the author himself, the aggressively chill Andrew Ryan. Andrew, welcome to the show.
Great to be here.
So you published this article. What's your general synopsis for people that can't, won't, or haven't read the article yet?
Absolutely. Well, so in the article, we kind of start with a broad appraisal of the empirical literature of the impact of value-based payment, which we broadly refer to as risk-based contracting, and think of it in many ways as synonymous with many ideas of managed care, but not all. And so basically focus on the body of literature that suggests that these programs have had a little to no impact on aggregate spending and certainly not bent the cost curve in Medicare. We then appraise another theory that's out there that has been referred to as the zeitgeist theory, that even though individual evaluations have shown little evidence that value-based payment maybe reduced spending, that perhaps writ large, there were these larger kind of spillovers to the healthcare economy that reduced spending growth. And, our view is that this theory is completely inconsistent with the evidence, which shows that spending growth in the United States began to decline in 2005, far earlier than the value-based payment programs that they occurred in other peer nations that didn't have value-based payment. And of course, more recently, we see an upswing in spending while VBP continues to be adopted. So we appraise that and feel that also does not support value-based payment working. And third, we make a broader conceptual critique about value-based payment, basically arguing that the long-term spending growth in healthcare, particularly in the United States, is very, very much driven by adoption of new technology and how it's priced, and that both the incentives and capabilities of providers that are subject to risk-based contracts and VBP make it more or less impossible for them to manage the kind of prudent adoption of high-cost medical technology. So we kind of conclude in this series by saying, value-based payment hasn't worked, but affordability, particularly in Medicare, is extremely important. And so we need an alternative set of policies that focus on fixing the fee schedule, that have a more aggressive approach towards covering new technology and managing prices and directly. And so this is really the agenda that we need for affordability reform in Medicare.
Yeah, so you talk about the evidence, and I know in the piece you discuss what you write as empirical reality. So, what is the evidence telling you about value-based care?
Yeah, sure. So first I'll start with the overall summary by the Congressional Budget Office, which found that many of the whole slew of programs that had been initiated by CMMI, all these value-based payment programs in Medicare, didn't save money, but instead actually increased spending in Medicare by about $5 billion. Now, a lot of folks have focused on this program, the Medicare Shared Savings Program. And, we also review the evidence there. And some of the early evidence suggested some modest kind of gross savings in the program. But then once we account for incentive payments that go back to participants, it kind of wipes out the gross savings. And then once you account for these selection and upcoding effects, we see what are very likely to be losses in those programs. So, we kind of highlight that, there's been some recent work on this program, the Medicare Shared Savings Program, but it doesn't change our view at all about how well VBP has worked or how it's likely to work in the future. Another thing I'll note is it's confusing because Medicare, CMS is often saying, this program saved $2 billion a year. And this year we saved $2 billion more. And we actually discussed this problem in another paper in Health Affairs called All I Do Is Win, which really discusses how the CMS evaluation of savings is relative to their own benchmarks as opposed to relative to a true counterfactual as to what would have happened if the program was not implemented. And again, we think that participants beating benchmarks is very much a function of upcoding and selection. So, writ large, this just gives us the view that we've put this idea to the test. We have a lot of evidence, and we conclude that this just is not going to do the trick. It's not going to be the solution to our long-term spending issues in Medicare.
In your article, you note these empirical realities are like, quote, that prevention is largely driven by non-medical factors outside of the control of the physicians. And you also go on to note that medical and wellness prevention efforts, have ambiguous net effects on spending, but they're worthwhile pursuing. I guess when you look at these models, and we've been in this era of value-based care adoption for quite some time, and with your review of seeing that it's not working out, why do you think this adoption continues in the face of what you say these realities are?
Yeah, I think that there are very seemingly strong theoretical arguments for value-based payment, and you just mentioned one of them. This idea is we're going to give incentives for quality and for managing disease. That's going to make people healthier, and then healthier people are going to spend less, and this is going to save money. And that sounds good, but that just basically never happens. That's just not a causal chain that has pretty much ever been shown that financial incentives make people healthier and they spend less and the system saves money. It just hasn't worked that way. So, and that's one, I think, incorrect theory about the mechanisms here. A second one has to do with just this broad view of fee-for-service incentives as being at the heart of our value problem. And you've probably seen it 100 times, 1,000 times. Fee-for-service encourages volume over value, and we need value-based payment to change that. And, my view here is that the field very much just over-indexed on kind of managing physician incentives and under-indexed on managing system incentives. And so this is I think this misalignment between how policy has gone kind of based on theory versus, and the field hasn't quite caught up with, the fact that in reality, these programs aren't doing what we hope they would do, and they're not up to the challenge of managing long-term spending growth.
Yeah, and so when you think about just even churn from a patient going from potential physician to physician, if their insurance changes or if they move to different insurance, what kind of theories with value-based care, what are you seeing with that?
Yeah, it's a huge issue because this idea, if you think about it this way, we're going to give a provider an incentive to keep someone healthier so that over time they spend less. And there's so many assumptions that are embedded there. I mean, number one is that whatever the provider does actually does make the person healthier and they spend less. Okay, that'd be great. But the second one is that over time, that same person is going to be attributed to that, that doctor or health system that helped them to be healthy and save money. And this is the churn point. I mean, people are always switching from insurance plans, even in Medicare, from who's your attributed physician. This is very routine that people switch around and you don't have longitudinal kind of management or accountability in many cases. And if that's the case, if you think about it, it's your physician is investing in you. They're outlaying resources to manage your care, to keep you healthy. But then a year from now, you might be with another physician and they wouldn't even get credit for whatever health benefits or financial savings occur. So this is just another basic, I'll say design problem where about VBP. And this sounds good in theory, but it kind of just runs up against some practical realities of how people receive medical care and from whom.
So we're going to go into counterfactual territory here, or maybe putting on your hypothesis hat.
Mm-hmm.
Yeah, that's definitely a saying that people say. So your article talks about how the slowing of tech adoption has been some of the cause of the healthcare spending slowdown. It's 2026, so I'd be remiss if I didn't ask about AI and AI adoption. And a lot of people have, posited whether they're going to benefit from it financially or not, that AI will help curb some spending or through adoption and make efficiencies. So, do you have any thoughts on, is there an intersection with AI tech adoption and value-based care that you foresee?
Absolutely. So a couple of things about this. So, I think in the article, we talk about the spending slowdown that occurred between around 2005 and, maybe around, say, 2019 or so. And that appeared to be driven by kind of a slowdown in the adoption of technology. But recent spending increases are driven by, an uptick with the GLPs and oncology drugs, among other things. So, again, we just think so much of this long-term growth is a result of technology. And to your point about AI, I'd say there's some short-term issues about, how different AI innovations that might kind of help management in the short term, say, related to remote patient monitoring or things like that, should be paid for in the fee schedule and stuff like that. And I guess my view is that, this stuff could be great, but, breaking out new codes for AI stuff is probably a bad idea. And, I would very much favor that AI-related innovations can be bundled in as appropriate within the current fee schedule and could perhaps change payment rates for evaluation and management or something like that to the extent that docs are, using this kind of technology. But I think the bigger issue here is that, if AI, and this is kind of the hope that will really push science forward and lead to the adoption of the invention of new therapeutics, new drugs, new devices, I think it just speaks to the importance of how we price these and to make sure that we have a sensible approach towards allowing new technology on the fee schedule and paying for it in a responsible way. I mean, I'll just say that right now, Medicare does not have direct authority to consider cost in making a coverage decision. So basically, if something is approved by FDA, it's covered. And, famously, Medicare doesn't negotiate prices for drugs, only under IRA has changed that to some extent. This just speaks to, I think, the importance of just the limited tools that CMS currently has in managing coverage and prices, which I think is just going to be all the more important to get a handle on so that we're able to take advantage of the potential, all the new therapeutics that could come online through AI technologies but not more or less go bankrupt covering a lot of low value stuff in the short term.
Yeah, so you said that CMS has limited capabilities to help manage spending. Is that correct? I don't want to put words in your mouth.
Yeah, well, I think too. It's kind of like this, especially on coverage. I think with respect to coverage decisions, CMS does have very limited authority and relatedly limited staffed resources to do this. So that's true. And I'd also say it's the same thing with the fee schedule, just governing the fee schedule. It's just not really a priority for how CMS operates.
What I was trying to get at is how would you like to see this evolve?
So I think two things, that we really call for in the paper is some full-scale reforms to the fee schedule. I think that there's so many distortions in the current Medicare fee schedule, how codes end up there, kind of the role of the AMA and the RUC and specialty societies and how codes get valued, often inappropriately. Just the limited oversight that CMS has in that whole process, which leaves lots of low value, overpriced new procedures, new technology on the fee schedule. The skin substitutes is a great example of that. That just shouldn't happen, but it happens all the time. So, having this whole scale, real change to the fee schedule. And these ideas are very closely tied to Bob Berenson, who's been talking about this for frankly decades, and he's right. And then second, I think is this more aggressive coverage policies, having the capability and authority to consider cost effectiveness for drugs and devices is huge. It absolutely is what CMS should have, that authority. They don't have it. So that's really essential, those two things.
So we had Troy and Brennan on the program to discuss his new book about primary care, and a lot of hope is pinned on value-based care for it to advance in that book. So given your opinions on value-based purchasing, how would you like to see the evolution of care delivery develop?
Yeah, sure. So I think that there's a couple important assumptions in health policy related to VBP and primary care that are mistaken. The first is that expanding primary care by itself will reduce healthcare spending. And, primary care is good. I will very much grant that it improves patient experience and may improve health, but the evidence that it actually reduces spending is very limited. And, as we mentioned before, it's the adoption of technology, how it's priced, that's really the driver of healthcare spending, not having primary care physicians try to avert hospitalization here and there. And I think it's been a real problem that primary care has been put at the focal point of cost control and rationing in these models. I think it in many ways, VBP has undermined primary care. And this is the second assumption I think is wrong, that, VBP is going to be good for primary care, that we need to support primary care through VBP. And I think that's exactly wrong. That VBP instead has added a lot of administrative burden, a lot of paperwork, a lot of risk management, a lot of coding, a lot of just non-clinical activities to primary care docs, and said, here, look, here's a bunch of stuff that we're putting on you. We think you guys are the best. You're the ones to do it. Go out and help reduce healthcare spending for us, which to me, it's been a total, it's under the guise of supporting primary care has really undermined primary care. And so, instead, if we want to make primary care better, want to make it more appealing, we should pay more for it. And, I think we've seen that through some recent CMS action that kind of aims to change the fee schedule by reducing specialist payment, increasing primary care payment. That's great, but I think we can go farther by getting docs out of, the MIPS and APM game. I think there's just so much that docs are being asked to do in the context of VBP that's frankly making their lives worse. And so I think there's kind of this deep irony that VBP is good for primary care when it gets actually the opposite that's true.
Well, Andrew Ryan, as we wrap up, is there anything that we didn't discuss regarding your article that you want to make sure listeners know about?
No, I don't think so. I think we've kind of gone down this path of value-based payment and risk contracting, and in many ways, Medicare Advantage has a lot of the same features, and it was based on a reasonable theory. But I would just encourage people in the field to appraise the evidence in the same way that we have, to not rely solely on the theoretical basis of these ideas, and just think more broadly and with a longer term perspective about what's really driving spending and how we can get a handle on it. That's what we really want to have happen to come out of this paper.
Andrew Ryan, thanks again for joining us today on Health Affairs This Week. The article, which you can read on Forefront, is Value-Based Payment and Managed Care Will Not Solve the Affordability Crisis. You can get a link to it in the show notes. And with that, if you enjoyed this episode, please share it with a friend, and we will see you next week.